Thank you very much, Klaus. Appreciate the introduction, and I'm absolutely delighted to be here. It's a beautiful country that you have here. The chief investigator for this study is Dr. Lamas, who we have difficulty pronouncing his name, so we call him Tony. And Tony has been involved in several major heart studies in the past. And as he told us, in a career of research, there may be 3 or 4 studies that you can get really involved in of major proportions, and this is one of them. So we're really delighted to have him as our chief investigator. Chelation therapy it goes back, it was discovered in Germany, I believe, in the textile industry. Basically, it was used in the United States early on to treat patients with lead toxicity. And in particular, it was in the automobile industry in Detroit, where Dr. Norman Clark was treating patients who had lead toxicity. And he noticed that a number of those patients also had heart problems, and they were getting better. And with that observation, he went ahead and did several studies treating heart patients and noted their improvements. Since that time, there have been many research projects performed, most of them by people who were giving the therapy. It was, at the time, perfectly acceptable research, but the large-scale double-blind studies, randomized studies, were not done. There were a few smaller studies that were done, and including the one that Dr. Hankey referred to that you'll hear a lot more about later on today. But also there was one in New Zealand by a cardiovascular surgeon by the name of Dr. Van Rij. And actually it got a lot of attention at the time, but he only had 16 patients in each group, in the treatment group and in the placebo group. And as it turned out, he didn't release the data to Dr. Godfrey, who is a colleague of mine and myself. And we tried for 2 years to get him to release the data just on those 32 patients. Finally, he did release the data, and we looked at it, and in the placebo group, there was one patient that had improved far and away better than anybody else in the whole study. So that really skewed the trial, so it looked like chelation did not have much of an effect. But if you took that one patient out, there was a very significant effect. However, and that was published in the New England Journal, or the New Zealand Journal, by Dr. Godfrey and myself as a letter to the editor. But of course, you don't see the published letters to the editor after the original article. So that article is still quoted as one of the main articles against chelation therapy in the literature. All the study, there was also the cardiovascular surgeon study that was done here in Denmark, and then there was a study in Canada that was for angina. And both of these were purported to be double-blind. Both of them had really serious flaws. But the biggest thing was they were way too small to have any significance. So we were stuck without a study. Along about early 1980s, the American Medical Association said, well, if you are going to have chelation therapy, then it's up to you to prove that it's effective, that otherwise it's unacceptable to use. Well, we said we didn't know much about research. Most of us are clinicians rather than research people. We did convince finally the Army to do a study at Walter Reed Hospital, which is the biggest Army hospital in the United States in Washington, D.C. And they did design a study for peripheral vascular disease. And they started it, and we were very excited about it. ACAM, which I later became president of the American College for Advancement Medicine, was a co-sponsor of the study. And it got going. They started randomizing people and so forth. And then along came the Persian Gulf War. And all the doctors went off to the Middle East. And most of them didn't come back. They came back to other assignments and so forth. So the study was dead in its tracks. And we were back where we started. So we continued to agitate, and finally we got an ear from Dan Burton, who's a congressman from Indianapolis, Indiana. And he was chairman of the Oversight Committee in Congress. And he had a child who had autism, who had chelation therapy as a treatment for the autism, and the autism was cured. So it was his grandchild, I'm sorry. And so he decided to have hearings on chelation therapy and invite National Institutes of Health, saying, all these people are taking chelation therapy. As you can see, in the United States, over 100,000 in a year, a little bit later. And he invited, and not only invited, he demanded the chairman of the National Institutes of Health Heart, Lung, and Blood Division come to that hearing. And he had 4 of us who did the chelation therapy, and I was one of those. So we testified about the results we had, and they didn't have any answer for it. So they finally decided to go ahead and do a major study on chelation therapy. Patients on the waiting list for bypass surgery. A very important study done here in Denmark by Hanke and Flightley. And this was a study done in the 90s. And everybody in the study was on the waiting list for surgery, either bypass surgery to the heart or peripheral vascular surgery, where amputation was threatened. It actually was proved to be indicated. And 58 out of 65 patients were able to cancel their surgery for bypass. 24 out of 27 were able to cancel their surgery for, in other words, their limbs were saved because they otherwise would have had amputation. So this really was a striking study. It's published in the Journal of Advancement of Medicine. And then about 7 years later, there was a follow-up study also published that showed very similar results in those same patients that had prevented the surgery. A couple of studies that we did. One is just a timeline. If you want to look at on the internet at www.chelation.me, you can find the detailed history and the key points. Along about the same time that Hanke and Flightley published their study, a little bit after that, we did a meta-analysis of 19 studies and 22,000 patients to see all the patients that we found in the literature had some measure of before and after to see if there was improvement with treatment of chelation therapy. And we found what we wanted to do was find out, is there a correlation between improvement in vascular disease and treatment with chelation therapy? And the correlation coefficient was 0.88. Of course, a perfect is 1.00. So that was a significant study as well. So getting back to the study that was funded by NIH, what they did is they sent out a request for proposals throughout the United States, and there were several proposals sent in. One was a hearing was conducted, and I was on the review committee for that hearing. It was very interesting because I was the only one that wasn't affiliated with a medical school, and there were about 25 reviewers in the room, and the presentation was made. And after the presentation was made, it went around the room, and each person gave a score as to how likely they think the study should be funded. Well, it went around the room, and everybody was giving poor scores around the room. I was the last one, and I gave a higher score than anybody else did. Yeah. I was kind of frustrated because I didn't think it was quite fair the way it was given. But afterwards, the head of the committee came over to me and he said, "You know, we always turn them down on the first try." And so, fortunately, there was a second try by the same group about 6 months later, and it was a smaller group, and I was on that one, and I was the first one to give the score. Well, I gave a little better score, but not as good as some of the others, and mine turned out to be one of the lowest scores as it went around. So they finally approved the funding of the study. The study was approved for $30 million, and it was initially thought to go over a period of 3 to 5 years. It's funded in 2002, and the first thing was to get an investigational new drug application, which was received in April of 2003, and then the study began. First of all, the investigators who qualified for the study had to go through additional training, not only on study techniques, research techniques, but also on the conventional treatment for heart disease, because everybody in the study had to receive conventional state-of-the-art evidence-based treatment for vascular disease, for cardiovascular disease. In order to be in the study, you had to be 50 years of age or more. You had to have a documented heart attack 6 months prior. You had to have adequate kidney function. That's creatinine less than 2.0. You had to have platelets at least 100,000 and normal liver function. And no revascularization procedure, no bypass or anything like that, within 6 months. And you couldn't have smoked, this was just by history, of course, within 3 months of the study, plus signing an informed consent. You also had to not have active congestive heart failure. In other words, you had to be able to tolerate the fluid load that was involved with the treatment. So the treatment solution was basically the solution that was formed by ACAM, the American College for Advancement of Medicine, back in the early 1980s. And that treatment protocol had been used by the physicians that had been trained in chelation therapy ever since that time. So the previous studies contain that same protocol, with one exception, and that is some of the research was done in 1.5 grams instead of 3 grams of EDTA, a shorter amount. But the rest of it was all pretty much the same. It contained the treatment solution into the EDTA, which was approved for removal of lead and other toxic metals, but no other active indication at that time. Vitamin C was in the bottle, magnesium, a few milliequivalents of potassium, sodium bicarb, and procaine were in there mainly to avoid pain during the infusion, and a little heparin to avoid phlebitis. There was added B1, B6, pantothenic acid, and that was all put in 500 milligrams of, 500 cc's of sterile water. No oral nutraceuticals except multivitamins were in the study. And they had the one solution of placebo, which contained just a few grams of glucose. One solution contained the EDTA and the other ingredients. And so another group had high vitamins versus low vitamins. So they had, it was actually turned out to be the largest study ever studied on high doses of multivitamins. And we don't have all the answers on that, that's coming up. But so patients could be in one of 4 groups, either with EDTA and low dose vitamins with EDTA and high-dose vitamins, without EDTA and low dose, and without EDTA and high dose. By the way, the study was later criticized because of putting glucose in the solution, but it's such a small amount that it really didn't have any effect. The primary endpoint for the solution was a composite patient of death, stroke, heart attack, the need for new surgery, either bypass or angioplasty with stent, and hospitalization for severe angina. So that was the composite was the primary endpoint. And that's a technique that is done in a lot of studies in cardiovascular disease today. The original plan, which was to have an 85% power to detect a 25% difference, required 2,372 patients with a follow-up of at least a year. Now, what happened during the study, there are critics of the study. There have been critics of chelation therapy in our country for many years. And sometimes they've even gone to the point of filed complaints against medical boards who have given chelation therapy. They've been, basically, they started through the pharmaceutical companies. They were funded through the pharmaceutical companies, and they also were an offshoot when the AMA, the American Medical Association, first had a committee on fraud. They were sued by the chiropractors, and they had to disband that committee, and this group kind of took it over. Well, anyway, they challenged the study partway through and said that it was dangerous and it was poorly done and so forth. Now, when that happens in the United States, there has to be an investigation. And there's a committee for that. And that investigation took place, but it actually stopped the study for a period of about 3 or 4 months. Well, as it turned out, all they did was add death as a possibility to the informed consent, and everything else was found to be fine. So the oversight committee found nothing wrong with the study. But what happened as a result of that was the study was delayed that a period of a few months long enough so that we didn't have to have as many patients in the study to get the same significance. And that was really fortunate because the cardiovascular surgeons throughout the United States basically boycotted the study. They didn't participate, they didn't send patients, and when their patients came to our group to be treated or included in the study, they discouraged it. They said, no, it's dangerous, you shouldn't do that. And I think we wound up with 39 patients in the study. Eventually we needed 1,700 for the same power. And I would say that probably at least 50% more did not participate, wanted to participate but didn't after talking to their cardiologist. So it was very difficult to get that enrollment, and it took longer than we thought. But then the biggest thing that happened that way is that Canada joined the study. And they gave us enough patients near the end that we reached a number of 1,708 patients, which is what we needed for significance in the study. So actually the opponents helped by prolonging it and giving us more time so we didn't need as many patients. 1,708 patients, 55,000 infusions. That's a lot of infusions, and it was a tremendous sacrifice by patients who knew that there was only a 50% chance that they were going to receive the actual treatment solution. And they were committing to 40 treatments. That would be 30 treatments at once a week, and then another 10 about once a month. So that's a big commitment. There are 134 sites throughout the United States and some in Canada. 40 treatments was the goal, although eventually, when you included dropouts and so forth, it wound up to be about 33 treatments per patient as an average. It was randomized, double-blind, and The other thing that was unique was the NIH usually does not fund studies for office-based physicians. And of course, most of the people who were recruited through known chelation facilities. And 60% of the sites were actually chelation centers, and only 40% were university centers. So it was a combination of university and office site research, and it went very well. One of the reasons it went very well is that you had to have all of the data entered for a patient before they would send you the next treatment solution. And it was all entered by computer, so it all went to the central location. And after they found out that you had everything entered, all the data entered, then they would alert the pharmacy who prepared the solutions, send them out to us with separate syringes for the vitamin C and EDTA because they couldn't be in the solution that long. And there were placebos for that too. So it was all done very carefully, and it's pretty hard to say how it could have been rigged. These are the characteristics of the people, and there are a lot more characteristics that are shown in the article that appeared. But basically, the average age was about 65 or 66. Diabetic patients, there were 32 in the treatment group, 31 in the placebo group. Previous surgery, 83% of the people in the study had previous revascularization. And 92% were on anti-clot mechanisms, in other words, aspirin or something like that. LDL, the average LDL was below 100, which surprised me that it was that good for both EDTA and the placebo. Those last two were important because they documented that the patients were getting traditional cardiovascular care, evidence-based medicine, as they say. Okay, the results of the study were there were 18% fewer cardiac events in the EDTA treatment group. Both groups got state-of-the-art conventional treatment. And interesting enough, the patients who received the high-dose vitamins with the chelation did slightly better than any of the other groups, of the 4 groups that were in there. So the high-dose vitamins did have some added benefit, probably because you're taking out some of the normal vitamins when you give the EDTA. So it was basically to replace those vitamins. 55,000 infusions, 65% completed all 40, 76% completed at least 30 treatments, and 17% withdrew consent. That was a criticism of the study, that there was a high withdrawal of consent. And the person who criticized it, which was in an article in the Journal of American Medical Association, said that indicated there was probably unblinding. That was the reason for that. People thought that they weren't getting the real stuff. In our clinic, we thought we could tell who was getting the treatment and who wasn't. In most of the cases, I think we were right, but a couple of cases we were wrong, and we were fooled by the placebo too. But there was no evidence of any unblinding anywhere in the solution, in the study. The study was first presented at the American Heart Association meeting in Los Angeles in November. It was published in March of this year in the Journal of the American Medical Association. The criticism was by Dr. Stephen Neeson, who's at the Cleveland Clinic. Interesting enough, the Cleveland Clinic is one of the universities that participated in the study. So he was criticizing his own group. But there are also participants, by the way, in the university from Duke did the statistics. Harvard followed up to document the adverse events. Ohio State University was in there. Johns Hopkins, Mayo Clinic participated. Major universities participated in the study, although none of them recruited as many patients as the chelation doctors did. Side effects and safety. 79 patients, 38 in the EDTA group, 41 in the placebo group withdrew consent. Some of the ones in the placebo group actually withdrew because they were convinced that they were not getting the solution and they went ahead somewhere else to get it. That was a few. 611 of the IVs finished 15 minutes early. In this study, 3 grams was the basic treatment, and if that took at least 3 hours. If it took less, that was not according to protocol, so that was an outlier. However, when we looked at the people that finished at least 15 minutes early, there were no adverse effects, no problem with their kidney function. The kidney function was monitored, so if anybody did show a reduction in their kidney function, which happens sometimes, then you just adjust the dose downward, and that was all done blindly through the pharmacies that were participating in the study, the central pharmacy. There were 4 serious unexpected adverse events possibly related to the study. 4 out of all 1,708 patients, and 2 were in the placebo group and 2 were in the EDTA group, and there was 1 death in each group. That's amazingly low considering that people were 65, 66 years old. All the patients in the study had to have a documented heart attack. So they were all at risk. None of Klaus's patients would have been allowed in the study because they had already been told that they needed bypass surgery. And if you were told that, you were not allowed in the study. But so this one big thing about this is it proves that the treatments are extraordinarily safe when given according to protocol. The patients treated in TACT, each one of these categories did not have statistical significance, but it was significant that they all improved more when given EDTA than when given placebo. There were 6 fewer deaths, 15 fewer heart attacks, 3 fewer strokes, 27 fewer revascularization surgeries, and that was the biggest category, 5 fewer hospitalizations. And this showed a pattern very similar to another study that we did that I'll get to here. The reason they weren't statistically significant was that there weren't enough events in there for it to be powered to give that result. However, it's interesting, they also did, one of the criticisms was, well, the revascularization procedures are more subjective. They're not as hard evidence. But when they went back and just looked at cardiovascular deaths, strokes, and heart attacks, still the EDTA group did better than the placebo group. The other thing that's interesting is that the longer patients were followed, the greater difference between treated and placebo groups. In other words, the patients were treated, did better as you went out in time. They continued to do better and better. They followed people for up to 55 months. And one thing that is significant about that, they did not continue to treat patients throughout that whole time. The most they gave was 40 treatments, which was about, a little over 1.5 years to 2 years. But they were following people for up to almost 5 years. And they still were getting better, a little better, out near the 5-year mark. And they speculated that one of the reasons for that could have been the removal of heavy metals so that the lesser amount of lead in the system, for example, continued to have benefit. Okay, there were 222 cardiac events, 26% in the EDTA group and 261, 30% in the placebo group. This was statistically significant with a p-value of 0.36, and that's what we needed for statistical significance. The largest difference came with the need for surgery, as I mentioned. This might be the most important part of the whole study as far as treatment effect goes. Diabetic patients given EDTA had 35 fewer cardiac events than those with placebo. That was a 39% reduction in diabetic patients in subsequent cardiac events. And remember, there were 31% of the patients in the study were diabetic, so it was a large number of diabetics in the study. And the biggest improvement came in the ones with diabetes. Also, patients that had previous anterior infarctions, myocardial infarctions, also had a much reduced amount of cardiac events. The p-values for both of those were very, very low. Now, we also did a study that was published in 2006 with basically the same endpoint. Now, this was not a randomized study, but what we did is we looked in the literature for comparable groups. And in the literature, we found out what were the chances of those groups. All the patients had vascular disease. What were the chances for them having heart attacks or strokes or some of the same endpoints that were in the TACT study? And this was a retrospective study. Dr. Henke participated. Also, Dr. van der Sar from the Netherlands, Dr. Olzewer from Brazil. We had people from around the world, around the country, the US country. There were 220 patients. It was not randomized, but it did have matched controls. In that, during a 3-year follow-up, we didn't have any deaths or any heart attacks. And we had a reduction of almost 90%. I knew this slide was going to get turned around. But anyway, we compared the study that we did to the study that was done through TACT as far as outcomes go. And in general, TACT patients were a little sicker because they had more cardiac surgeries at baseline. TACT patients received a little more than half the number of treatments. Now that's very important. Remember, I said that the TACT patients averaged 33 treatments in the treatment group. In our group, the average was 58 treatments. In other words, 30 treatments and then monthly maintenance during the 3-year plus follow-up. So it was almost twice as many treatments in our group, and that may be one reason why the results were significantly better in our treatment group. For both studies, the number of surgeries was the biggest change. And the other thing was that we tried to compare to see if the 3-gram dose of EDTA was more effective than the 1.5-gram dose, and we couldn't. The 1.5-gram dose was equivalent. They had just as good results. So a lot of doctors in the United States use the 1.5-gram dose. This was first suggested by Dr. Olzewer in Brazil, who had a massive amount of patients. So in our clinic, we give the patients a choice whether they do one or the other. But we also are very careful to note that given this amount over a short period of time using calcium EDTA instead of disodium EDTA, which is what we used in the study, was not part of any of this research. And some doctors in the United States are using a short push of calcium EDTA because that can be given over a short period of time. But there's no evidence that calcium EDTA improves vascular disease. It may have some effect by removing lead like the other solution does, but it's more than just removing lead, we believe, and we use the disodium EDTA. Now we have to be very careful about that because there have been a few deaths in the United States of doctors who took the disodium EDTA and gave it as an IV push instead of over a gram an hour, basically. And there have been 3 or 4 deaths reported. All of them occurred when they gave the wrong kind of EDTA. So you have to be sure you're dealing with the right kind. The reduction in cardiac events overall was statistically significant and TACT. The biggest change in both studies was a reduction for the need for future surgeries. The other thing they looked at briefly was quality of life questionnaires. And there wasn't a significant improvement in quality of life questionnaires, but they did it for only a short period of time. They did not complete it, and they said that they quit too early to really have any significance. Because in the studies that we did in experienced chelation doctors, we saw a big change in quality of life. Much reduction in angina and in improvement in walking distance and less claudication. We saw that across the board. So I don't have a full explanation of that, but it wasn't done. They admitted that it wasn't done accurately enough. In the article that was published in the Journal of American Medical Association, that was published March 27th, I think it was, there were two accompanied editorials. One was by the editorial board of the Journal of American Medical Association, and the top three editors wrote an editorial explaining why they accepted the article, because they went through extremely rigorous peer review and really grilled the doctors who submitted the publication. And they got responses they felt were scholarly and very responsive to their questions. And they felt like it was very important to publish it, even though they didn't necessarily agree with the results. Then there was another editorial by Dr. Nisan that I mentioned from the Cleveland Clinic, and he was clearly negative on it. But he's been clearly negative for a long time, even before the study was done. So he had a history of that. So, patients who benefited most. Diabetic patients, patients with more severe heart attacks. Conclusions. EDTA is a safe treatment. Only 2 unexpected deaths, 1 in each group. Chelation therapy showed an unexpected treatment benefit in post-heart attack patients who are already on evidence-based therapy. That's a direct quote out of the article, by the way. Now, the effect was statistically significant. Now, what they also said was, the authors said that additional research is needed to confirm the results and explore mechanisms of action. And they also said that this is not sufficient to make EDTA a routine part of cardiac care. And I'm sure this was negotiated, how this was worded was negotiated with the editorial staff intensely, because it took over a year to write the article after the data was collected. So it was all done carefully. However, there are several more studies pending, several more articles coming out as a result of this study. One on the vitamin treatment and one on parts of the endpoints. In fact, several on parts of the endpoints. And talking to Dr. Lamas, Tony Lamas, he said these will be even more controversial than the one we published. So it'll be interesting to see how they come out. Most of the patients, of course, were recruited by chelating physicians who were experienced with chelation. And at the end of the study, most of those physicians really find it unethical to treat placebo patients over that length of time in any further study that might be done. They'd be willing to participate in registries and serve as consultants for other physicians. But realistically speaking, they're not going to spend another $30 million and do another 10-year study. They're going to have some lesser study that is a confirmation. The response from cardiologists have been mostly negative. They tend to accept scientific evidence, of course, if they agree with their prejudices, and the prejudices have gone on for a long time. The criticisms by cardiologists of chelation therapy go back to the early 1960s, and there have been many editorials written against the therapy in the interim. This is true even though the professors of medical schools participated in the study, and the statistics were done by the Duke University, which is very, very rigorous as far as it's done of statistics. So they were not manipulated. I think that was a concern before the study. A few cardiologists have said the study needed to be done and the findings might be important. But talking to Dr. Lamas, he said that more and more physicians are now taking a careful look at the study, and he's getting more and more positive feedback about it. So that is encouraging. What we have, this is the only large-scale, randomized, controlled study on chelation therapy. The only one, and it is positive. The only one that is statistically significant. The strength of evidence, to give you an idea, is about the same as it was for clopidogrel, or Plavix, for use in cardiovascular disease. So it's about the same. Chelation therapy is particularly effective in avoiding vascular surgery, as was proven in Denmark, and diabetics do especially well. I think all diabetics should be offered chelation therapy, in my opinion. In stable patients with a history of MI, the use of EDA compared to placebo modestly reduced the risk. This is again out of the article. These results provide evidence to guide future research or are not sufficient to support the routine use of chelation therapy. Maybe not the routine use, but I think it should be included in the informed consent, and patients should at least have that option because it is evidence-based medicine. More research will be done. The mechanism of action will be explored, especially more about heavy metals. They did not look at heavy metals in the study. They didn't have enough in their $30 million to look at heavy metals, I guess. But that's certainly one thing that many of us do, and that is to look at, to see not only about lead, but also aluminum and mercury and cadmium and arsenic. And that whole accumulation of a group of heavy metals, I'm sure, is worse than the individual metals themselves. And there are certainly plenty in the standard medical literature showing that lead provides high levels of lead, even slight levels of lead, increase the risk of chronic degenerative disease, including vascular disease, hypertension, autoimmune problems, and cancer. One of the big things is, since we have this evidence-based study, it's very good defense. So, I mean, we don't have to worry about it. We don't have to worry that medical boards are going to attack us because we have this in our defense. And that's a big breakthrough. Insurance and Medicare, of course we have both in the United States, might slowly begin to cover the therapy in selected cases. And actually Medicare in the United States has a pilot study where they're covering EDTA for documented lead toxicity in patients with vascular disease. I don't know what they'll do with it, but they are doing it very slowly. Myself, as Klaus mentioned, I've devoted a good portion of my life to this. I'm president of a couple organizations. But it's not only me by any means. There's Dr. van der Schaar has trained doctors all over the world. Efrain Olzewer in Brazil has many more physicians who do chelation therapy than in the United States. There's activity here in Denmark, which we appreciate very much. And so there are places all around the world. New Zealand, interestingly enough, has a pretty active chelation group. More so than Australia, by the way. And there's some in the Philippines and in the Far East. So it's a worldwide movement with pockets here and there. The skeptics will continue to criticize our work. But we've been very persistent because we've seen the benefits. I've taken 275 treatments myself. If a patient doesn't show up, I get the leftovers sometimes. So talking to patients. Some of us are patients as well. If you have any risk at all for cardiovascular disease, I would say yes, you should take it. If your family history is positive, yes. If you're positive for heavy metals, which we do on more and more patients, yes. If you're concerned for prevention and the #1 cause of death, yes. And especially if you have diabetes, especially so. Oral chelation has also been promoted in the United States, especially through the mail and some through health food stores. Oral chelation therapy is calcium EDTA. It's only 5% absorbed, so it really cannot be absorbed sufficiently to remove toxic metals from the body. And there have been no studies that have used oral chelation therapy, although the people who are in favor of that oftentimes quote the studies that we've done on intravenous EDTA saying that it applies to oral, but that's not the case. However, there is one case when it might be indicated, and that is especially if you suspect ongoing exposure to lead, for example. Then if it's 95% unabsorbed, that's good because it will be binding the lead before it's absorbed into your body. So there's an indication. We had a summit meeting. I'm on the board of directors of the International College of Integrative Medicine now. We held a summit meeting in Washington, D.C. in March, and this was just before the published article came out. And there are representatives at the meeting from the countries listed here from the U.S., Canada, Indonesia, Brazil, Denmark, the Netherlands, Germany, Ecuador, and New Zealand. And what we wanted to do was explore where we go from here with chelation therapy. TACT proved the safety, and it supported its use as an option anyway in treating patients with cardiovascular disease. Consideration should be given to doing a challenge test on all cardiovascular patients. More research is needed, and the consensus was the peripheral vascular disease is the most likely to show benefit. And they're especially impressed by the limbs that were saved in Hankey and Flightley's article. Other areas of possible research were discussed, including Alzheimer's disease. There's been some recent work about fibromyalgia, like 90% of people who are tested for heavy metals treated with chelation therapy show significant improvement in fibromyalgia, which is a tremendous improvement in a difficult disease. I'm just starting to work with an ophthalmologist from Florida and doing a nationwide effort to treat people with macular degeneration and glaucoma with EDTA chelation along with some electrocurrent treatment. We need to look at lab biomarkers and find some others to use, although certainly the heavy metals. The heavy metals need to be done with a challenge test rather than just certainly not with a blood test, because the metals don't stay in your bloodstream very long, maybe up to 2 weeks. So if there's an industrial ongoing exposure, yes, you might find it, but otherwise the lead goes into the bone and into the brain, to the soft tissue, and you have to pull those metals out into the urine to find out how much is stored in the body. So you give a test dose of EDTA, collect the urine for 6 hours, and then you can get a much better idea of what the heavy metal burden is in the body and how many treatments may be required. Doses of EDTA and vitamin C, we don't want to go too far as we have this one study using 3 grams, and then we have some comparison with 1.5 grams, but otherwise, the doses I don't think need to be changed much. If they do, then it's going to be kind of chaotic as far as what is working where. There is some controversy about vitamin C. In the study, 7 grams was used, and in the there's some concern that higher doses of vitamin C might increase free radicals and be a pro-oxidant rather than an antioxidant. So some people are starting to use a little less, more like 3 or 4 grams of vitamin C. International organizations like occur around the world that I mentioned communicate, but we can work more closely together. The big thing we need to do is raise public and political media awareness, and that is essential, I think, as far as acceptance goes. So here's contact information. That'll be on the slides, and I'm happy to communicate with anybody, and I'm also happy to answer any questions that you have.
Thank you, Terry. I like one of your slides with the word, you can measure your success by the power of your enemies. I like that. Any questions for Terry for his presentation? I would like to ask you about the people discontinuing the dropouts, the dropout patients. There were a little more in the placebo group than in the EDTA group.
Yes.
That seems natural. In the placebo group, you're sitting there week after week, not getting any benefit, not feeling any benefit. It's just a lot of fuss to get there and so on. Can we use that as an indication of benefit in life improvement?
I think it's really hard to do that, because in your when you're treating people with vascular disease, some people are early responders, and the first treatment they start feeling better. Others are very late responders, and they may go through 30 treatments and not notice that much benefit, but then at 35 of maintenance, all of a sudden they're feeling much, much better. So there's a delayed effect in some people. So it's really hard to predict that, and I think that was reflected in the dropout rate. The other problem with the dropout rate is, of course, the United States, there's more areas you need to drive, longer distances. So we had some people in our study that were driving 60 miles for each treatment, and that got to be a burden. And so any study that required a 3-hour IV 40 times is going to have a higher dropout rate.
Of course. Mm-hmm. We had this study of the international groups of clinics with way better results than this one. Do you think the treatment in the TACT study is suboptimal? Could it be done better?
Absolutely. I think that the people that are trained to give the chelation in their offices do much more than just give the EDTA. They treat with nutraceuticals, vitamins, minerals.
Diet.
They do other testing.
Diet.
Yes, diet. More attention to lifestyle factors a lot of times. So I think that is a more comprehensive treatment than just the EDTA. But when you're doing studies, especially randomized control studies, they want to minimize the variables. So there was a lot of discussion about how they were going to do this study. They wanted to duplicate as much as we could the protocol, but they didn't want to do the other things because they were afraid that that would show that there's a benefit that wasn't there just to EDTA, you know. So I think that the reason our studies, and it's not just the international study we did, many other studies were done by chelating physicians that showed a much greater benefit, extending back from the 60s all the way up into the 90s when the TACT study began. All of the patients in the study were given statins, and they were given beta blockers, they were given aspirin, so you had to have a treatment benefit above what they would get from evidence-based medicine in order to have a positive result in the study. Yeah.
So if we discontinue statins, we will get better results.
A lot of people feel much better during the study, and they have more energy. There's some people that feel a little bit tired of the day of the study when you're taking out some of the minerals. We try to compensate for that by giving not only the oral vitamins and minerals, but sometimes we give intravenous ones to fortify the patient before they take the treatment, or if they're feeling weaker during the treatment. You know, I don't think that's ever been studied or looked at. You know,
I did, Terry.
Injectable.
I did.
You did? Well, go ahead.
I contacted the patients. I knew exactly who they were. So it's not a statistical study, it's a case study on each patient. And I called them. And of course, first time you are afraid to get the widow in the phone. And it was patients started Edta Chelation Therapy 8 to 12 years ago. So it was really a long-term efficacy. And it showed very much sustainability of the treatment results, the first ones. So as far as I remember, if of the 35 patients I had primarily standing for a bypass surgery 12 years after, if all 35 were operated, 14 would have been dead 12 years after. There died only 3 in that period. So only that, just that hard evidence is very convincing. And I think 65%, it's hard to tell percent of 35 patients, but I think 20 or 22 never got bypass surgery. They stood before it. So the indication were there, but they were never operated. So that could save a lot of money, of public money, and the patients, they did well.
Yes, and as we said, that one speculation may be a lowering of toxic metals, because those toxic metals stay with you the rest of your life. It's a lifetime accumulation. But I don't think it's just that, because the antioxidant level of the EDTA and the vitamin C, I think, improve endothelial function too. And we do measurement of plaque before and after treatment. And we do see improvements in most patients who get the treatment. Now, it doesn't eliminate the plaque altogether, but you see smoother plaques, not as big, not as irregular as you might see otherwise, as you saw beforehand. He was not, what was the last part?
How can he be a part of the study when he is on the payroll of 10 medical companies, pharmaceutical companies?
Good point.
Yeah.
He was not in any way part of the study. He was an outsized critic that they found. He did not participate in the study. He's just been against the study from the very beginning. And probably for one of the reasons that you mentioned. Yes, he's done many drug studies, and he's used the same endpoints that he criticized in the TACT trial, in his own studies, you know. So I don't have a lot of faith in what he said, but they wanted to show fairness by giving him a chance to speak. Part of the funding was the physician received $100 per treatment, and the patients did not have to pay anything. And they also got their vitamins for free. Yeah. And that was one thing we could say, if you participate in the study, at least we can give you free vitamins for the length of the study. So that gave him something. Can we improve the absorption of it? I'm not a chemist. I don't know. I don't know. They haven't been able to for many years. It's a compound that is not really changed in the body. It's not metabolized, so it just goes in carrying one mineral, drops that, and has a greater affinity for another one. So it'll go in carrying magnesium, and then come across the lead ion, and then they'll drop the magnesium, pick up the lead, and then just go out through the kidneys. So it's not changed when it's absorbed or processed in the body.
But the problem with oral chelation is also that you can never make the peak concentration of EDTA, which will make the peak low calcium to provoke the PTH in the thyroid. So you cannot get the efficacy of removing plaque.
Yeah, that lowering of the calcium, disodium EDTA lowers the calcium quite a bit right during the treatment. That's been measured, and it's like 1/3 the level. And there's no problem with that because you're sending high doses of magnesium along with it, and that prevents any problem. But that lowering of the calcium, as Klaus has said, triggers the parathyroid gland to mobilize calcium and bring it out of the plaque or other areas where it might be stored. And that's good, because if you have metastatic calcium in the wrong spot, then you want to get rid of that. However, if you did that every day, then you'd lose calcium from the bone, and then you'd have problem with osteoporosis. Whereas with EDTA, we give it once or twice a week, and that pulse treatment actually strengthens the bone rather than weakens it. Yes.
Any other questions? Then Terry, do you have any personal experience in your many years as a chelation doctor to give us? Anything special to add from your personal experience?
Well, I started giving chelation therapy at the insistence of one of my patients who came to me, and he was a CEO of a corporation, and he had patients who were traveling 200 miles to get the treatments. And I insisted, well, it can't be that good, or else I would have learned about it in medical school. And it took him about a year to convince me to just visit a couple of doctors who were giving the treatments. And I did visit the doctors, and they were impressive, they were fine, but the key thing was talking to the patients, because there's one story after another of really spectacular results, and some people that were very, very sick, and they now are doing fine. You know, they were, they avoided amputation. They had been in the hospital. One person had been in the hospital 1/3 of his life for the previous 3 years. He was in intensive care, and after he started getting chelation, the next 3 years he wasn't in the hospital at all. So I gave treatments on the basis of helping patients for several years. But then I developed angina several years. Coincidentally, I had a nice treatment for it. And so that's one reason why I've had the 275 treatments. It's not just for prevention, but I no longer have any trouble with that at all.
Sounds very much like an experience a lot of us have had. Mm-hmm. Yeah. Provoked by the patients we started.
That's right.
Yeah. Okay. No more questions? Then we thank you very much, Terry.
Thank you.